Welcome, everyone. Thank you for joining us for one of our August faculty development sessions around race in healthcare training by Drs. Deyrup and Graves. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. Just a few housekeeping items before I introduce our speakers. This presentation is being recorded and you will have access to the recording and slide presentation for future reference. We invite you to submit any questions in the chat and we'll get to as many as we can by the end of the session. We do ask that you remain muted with video off unless asking a live question to assist with the recording. Also, this session is eligible for CE credit and you'll receive the website and activity code before we conclude. There is a short survey associated with the continuing education, and we thank you in advance for providing feedback as we continue to build robust programming for our faculty and staff here at Creighton. Now, I am very excited to introduce our two presenters today. Dr. Andrea Deyrup is a pathology professor at Duke University School of Medicine. Over the past 7 years, her career has focused on medical education when she joined Duke Pathology as course director of the first-year medical school. She served on the UME Council for the Association of Pathology Chairs, participated in the Duke Teaching for Equity Fellows Program, and was a member of the Duke School of Medicine Health Professions Anti-Racism Task Force. Dr. Deyrup also co-edited the new Robbins Pathology textbook, Essential Pathology, and I think there's a new one coming out as well. She is actively committed to anti-racism efforts and to improving discussion of health disparities in medical education. Dr. Joseph L. Graves, Jr. is a biological sciences professor at North Carolina A&T State University and Associate Director of the Triangle Center for Evolutionary Medicine through Duke University. His research in evolutionary genomics of adaptation shapes our understanding of biological aging and bacterial responses to nanomaterials, and he has written multiple books on the biology of race. I won't list them all now, but I will include the titles in the chat for you later. Dr. Graves leads programs addressing underrepresentation of minorities in science and aids underserved youth in Greensboro through the YMCA Chess program. Dr. Graves currently serves as the science advisor to the Chicago and New Brunswick Theological Seminaries. We're grateful to both Dr. Deyrup and Dr. Graves for their willingness to share their time and knowledge around race in healthcare training. So, Dr. Deyrup, if you're ready to begin, I'll turn it over to you.
All right, well, thank you very much. I have to tell you, we are absolutely delighted to be here. And in particular, we really appreciate how you recognize that systemic racism is throughout healthcare training. Typically, we call our talk nearly everything you learned about race in medical school is wrong, but you very correctly pointed out that, you know, it's not just medical school, it is everywhere. So I'll begin with a disclosure. As Dr. Seaman mentioned, I'm a co-editor author of 2 of the Robbins pathology textbooks, and Dr. Graves is a paid consultant for Robbins and Kumar basic pathology. So over the next 45 minutes or so, we're going to discuss the impact of systemic racism in health professions curricula, compare and contrast biological race and socially defined race, evaluate disparities in the pathophysiology of disease, and describe an approach to addressing health disparities in healthcare education. So the first question is, how does race show up in the curriculum? Now, I'm a pathologist and I teach in a medical school, and this is the book I use. And so to get an idea of the depth and breadth of the issue, I searched the electronic book using terms like Caucasian, African, Hispanic, Asian, and I found more than 35 different diseases for which some sort of difference was associated with socially defined race, either in incidence or prognosis. And I've listed some of them here for you. Now let's take a look at how these show up in the textbook. So here are some direct quotations from the 10th edition of Robbins, talking about African Americans and cardiac amyloidosis. carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and whites with factor V Leiden mutation. So just for the moment, let's set aside the outdated terminology, which should be very easy to fix, but is surprisingly sticky. And let's recognize that when these sentences were written, they were written with the best of intentions. The goal was that by having these epidemiologic data, that healthcare workers would be able to come up with an appropriate differential diagnosis, order lab tests that could confirm that particular diagnosis, and ultimately design optimal care for the patient. So these sentences were written with the best of intentions. But as we all know, particularly those of us who do anti-racism work, it's not enough to simply say, I have good intentions. We have to ask, are we causing harm? So are we causing harm? And I think we are. So there are three areas we're going to look at, the first of which I call buzzword bingo. So this is where we take highly motivated, very bright students, and we teach them simple word associations. White, cystic fibrosis; Black, sickle cell. And we reinforce this through patient vignettes, through exam questions, and through the boards that they take, and including the preparatory materials for the boards. So let's take a look at a recommendation for the medical school board, step one. Those of you who are sitting in the audience looking at this, I'm sure on the one hand, you're going to recognize this is written with irony and sarcasm, but you're also going to recognize that these are associations that we have all learned as part of our education, and that knowing these helps us do well on multiple choice questions, these quick associations. Now, that's just a website that was written by a resident who was trying to give some advice for medical students. We can't really look at what the boards look like. Those are privileged and protected materials, but we can look at perhaps the next best thing. So these two authors, Rip and Braun, surveyed the question bank from UWorld. And UWorld is used by more than 400,000 students across the world, about 250,000 of them in healthcare. So not just for medical students, but nursing students, PA students, et cetera. What these two authors did was they queried the question bank for the medical boards for step one, which is the clinical knowledge that medical students need to pass. And they searched this question bank, more than 2,100 questions, using terms which you can see here related to race and ethnicity. And they found that in about 20% of cases, there was some mention of race or ethnicity. So they further categorize these as whether it was descriptive or central. So descriptive would be something where the person just happened to be whichever one of these different races or ethnicities, but central would mean that knowing that patient's race or ethnicity was going to help you come up with the correct diagnosis, the correct answer to that question. So we can see here, if we take a look, if we look at the white/Caucasian group, we see 93% of the time that person just happened to be white. So maybe they were in a car accident or they had a cold. 7% of the time it was central. So that could be something like cystic fibrosis or coronary artery disease, which for some reason was firmly associated with this group and not with other populations. Now, as we look at this, one thing we need to notice is that this grouping accounts for 86% of the total mentions in the database. And that's a lot, particularly when you consider that only 62% of the population in the United States is identified as white/Caucasian. So already we have this focus on white populations. But I find even more egregious this association with Native Americans. First of all, they only very rarely appear in these vignettes. And when they do, the fact that they're Native American is central to getting the correct diagnosis. So this person wasn't in a car accident or brushed up against poison ivy. They are there because they are Native American and they have lactase deficiency or severe combined immunodeficiency or gallstones, right? So we are reinforcing these. Now you may be saying, well, okay, yes, you learn these when you're doing the, the education, the didactic part of your curriculum. But, when you get on the wards, when you're actually out seeing patients, you're going to learn that these things really don't apply. And there's this huge spectrum of health and disease. And I would counter that by saying there are things that I learned at the University of Chicago, an excellent institution 20 years ago, that I did not learn were false until I began really looking at race in medicine. So the next question we have to ask, of course, is, are we causing patient harm? So are we? And I would say, yeah, again, I think we could be. So say a young Navajo woman presents at an acute care clinic. She's got right upper quadrant pain, and the nurse practitioner or the physician or PA says, oh, American Indian, got to be gallstones, and doesn't think to exclude an ectopic pregnancy or acute appendicitis, either of which can kill the patient. Now, again, you may say things like this don't happen. We have checks and balances. We have algorithms. Well, here is a story about cystic fibrosis. And this comes from an article called The Misuse of Race in Medical Diagnosis. And in this, the author recounts a story of a childhood friend who wasn't diagnosed with cystic fibrosis until she was 8 years old. Now, most kids are identified by the age of 2 months. And she kept presenting again and again with suspicious symptoms. And it was only when an attending physician literally could not see the color of her skin, made the diagnosis, looked at the chest film and said, hey, who's a kid with cystic fibrosis? So again, I think we are causing patient harm. So then, as long as we're looking, we got to step back and say, is there a way we are causing societal harm? Is there a way we are lifting one population up and putting another one down? Are we saying risky choices, bad decisions, bad genes, non-compliant, right? Are we setting up some sort of hierarchy? So to make this clearer for you to visualize, I am going to redline the diseases in the 10th edition that are listed as being more common or worse in individuals of African descent. And for comparison, here are in individuals of European descent. So yes, I think we are causing societal harm. And finally, it's very important we think about the health of our learners, right? So this is a quotation from Dr. Damon Tweedy's book, Black Man in a White Coat. He was a medical student at Duke before I got there. He's now one of my colleagues on the faculty. And this is the drumbeat of race that we are saying again and again to our students. It seemed that no matter the body part or organ system affected, the lecturer would sound a familiar refrain. It's more common in Blacks than in whites. Each time the demographics of a new disease came up in a lecture, my stomach twisted. I knew where this was heading. Seated in a sea of mostly white and Asian faces, I wondered how this information affected their views of Black people, whether they already had biases against us, and whether any of this impacted the way they saw me. So I think we can say here, this is also showing the societal harm. So we're talking a lot about race. Let's take a step back and say, what do we mean when we talk about race? I'm going to turn this over to Dr. Graves.
Thank you, Dr. Deyrup. And I want to make the point that no one should feel embarrassed by not really understanding what we mean by race. Just to give you an example, I literally, before I got on this talk today, I was asked to review a paper for a prestigious medical journal, generally well-written paper, but the authors really didn't get it. They did not understand the difference between social definitions and biological definitions of race. So in modern biology, races are defined by two criteria. The first is the amount of genetic variation within and between groups. And the second is whether a group within a species can be considered a phylogenetically unique lineage. Now, we've long known that humans show more variability within so-called races than between them. However, it's important to recognize that we do have geographically based genetic and physical differences. But any two individuals drawn at random on this planet share 99.9% of their DNA nucleotides in common. But to make this point even more clear about the confusion here, if we were to choose one individual from Africa at random and one individual from Europe at random and compare them, and take one individual at Africa from random and compare them to another individual from Africa chosen at random, the two Africans would be furthest apart in their DNA composition. And that's because there's more genetic variability on the continent of Africa than in the rest of the species. Next slide, please. Now, all this to tell you that while biological races can be defined using modern genomic and phylogenetic techniques, that tells us that biological race does not exist in modern humans. Now, I want to emphasize this point, that it's one thing to say, race is a social construction, as many social scientists and humanists do, but they can't actually explain to you why the biological race criteria fail in modern humans, as per the definitions we gave on the last slide. Now, this biological race concept differs from socially constructed or socially defined race. The latter arbitrarily utilizes aspects of morphology, geography, culture, language, religion, but this only is done in the service of a social dominance hierarchy. So in my last book with my colleague Alan Goodman, the title was Racism, Not Race. And by that title, we meant to get across the point that it was racism that drove the definition of socially defined races, not the underlying biological variation within our species. In fact, that really wasn't what people were concerned with at all. They were concerned with these other attributes of human beings. Now, this recognition is beginning to become more widely accepted. So, for example, in Merrill's 2017 Introduction to Epidemiology, they say race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. Note that they do not say that these variations are mainly driven by genetic differences between supposed racial groups. Next slide, please. Now, this really becomes clear when we look at the categories of the US Census. For example, white, a person having origins of any of the original peoples of Europe, the Middle East, or North Africa. But of course, this begs the question, how much of that ancestry does one have to have before they are defined as white? Black or African American, a person having origins in any of the Black racial groups of Africa. Again, how much variability? African American or Africans, sorry, contain more genetic variability than all the rest of the world combined. American Indian or Alaska Native, person having origins of any of the original peoples of North and South America, including Central America, and who maintains tribal affiliation or community attachment. So someone with this ancestry simply has to cut their tribal affiliation, and they're no longer considered American Indian or Alaska Native by the US Census. Asian, person having origins of any of the original peoples of the Far East, Southeast Asia, the Indian subcontinent, including, for example, Cambodia, China, India, Japan, blah, 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 blah. Now, again, this is a huge expanse of human geography, and all of these people are considered as the same thing, which makes this category virtually useless. Native Hawaiian or other Pacific Islander, person having origins of any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islands. And again, we come back to the same question that motivated the other categories, exactly how much of that ancestry does one have to retain before they're no longer counted as that group. Next slide.
All right, so I think that was an excellent description of socially defined races. Let's take a look at how this plays out in health. So a lot of those criteria seem to be geographical, so let's look at a map. So this is a map showing the distribution of a number of hemoglobinopathies. thalassemia, sickle cell, hemoglobin C disease, etc. And as you are all aware, these diseases developed and became prevalent in areas where there was mosquito pressure because of malaria. And so the heterozygotes tend to have an advantage. Therefore, this allele propagated in these populations. And as we look at this map, you can see that while we can say a lot about the distribution of mosquitoes and malaria, we can't say a lot about how different geographies perhaps relate to socially defined race and disease. Because if we look at thalassemia, well, yes, it affects parts of Asia, but not so much other parts. It affects parts of Europe, but not other parts. And it affects parts of Africa and not other parts. And if we take hemoglobin S, sickle cell disease, which as you know, is very closely linked to African Americans in the United States, you can see here, yes, it is found in parts of Africa, but also Southern Europe, parts of the Middle East, and India. So we can't really say anything based on geography and socially defined race that links us to disease. Now let's look a little bit more closely here at Africa. I think this is very instructive. So we can see here we've got a fair amount of hemoglobin S, we've got some hemoglobin C, and then we have this area where there's no thalassemias at all. No hemoglobinopathies at all. And you may be wondering what's going on here. Well, that's where the Sahara Desert is. There's no water, no mosquitoes, no malaria, no hemoglobinopathies. So that really, I think, shows us that this is not about socially defined race or even geography. It has to do with pressure from malaria. Now, as we look at Africa, and as I mentioned, sickle cell disease is very closely associated with African Americans here in the United States. And if we were to compare this map to a map showing the origin of enslaved peoples in the history of our country, even if you knew nothing about modern day America, you would expect there to be some hemoglobin C and a fair amount of hemoglobin S. And you would be right. So this is just a single study coming out of Howard University, the sickle cell screening clinic. And they found that about 10% of individuals had one sickle allele. And then we had some hemoglobin C, et cetera, as well as a few people who were homozygotes for this. But one thing to keep in mind is that while we see this, there actually are differences between sickle cell trait, which is the heterozygote in the United States and in Africa, because in the United States, we no longer have pressure from malaria. Malaria continues to be a very catastrophic illness in Africa. So you continue to see that selective pressure in Africa. Now, you may be thinking, okay, I can't say African Americans are associated with sickle cell, but maybe if I think about the geography and if they come from a certain area and this person looks African American, but we can't tell by looking at someone where they are from in Africa. And we also have this issue, as I mentioned, of people who are migrating here more recently. So about 9% are immigrants, some of them coming from areas which don't have any sickle cell, no pressure from sickle cell. And the important thing to consider as well is that we have to consider population admixture. So the mean amount of European ancestry in African Americans is about 16%. So population admixture is so important. I'm going to share this now with Dr. Graves to discuss this.
Yeah, so one of the misconceptions about, particularly African Americans is not understanding that the mean European ancestry in African Americans is quite variable. So if we look at the Southeast, which was the cradle of chattel slavery, the amount of European ancestry in African Americans is relatively low. It's around, on average, 15%. However, if you look at a state like West Virginia, which, by the way, is in that same region, it goes as high as 30%. In Washington state, it's also in excess of 25 to 30%. So this means that depending upon which portion of the country, the averages of European ancestry in people socially defined as African Americans or Black can vary tremendously. And this can also vary tremendously within relatively closely related individuals within families. Now, next slide. This is even more complicated for people that we call Latinos or Latinas. because they exist as a tri-admixture between Europeans, Africans, and Amerindians. So the mean European ancestry in Latino populations is anywhere between 65 to 85%. But then the other admixture percentages of Amerindian and African American can, again, vary dramatically. Next slide. For example, in Puerto Rico, the average ancestry of Puerto Ricans is about 72% European, 16% Amerindian, and 12% African. However, in Mexico, which represents the largest number of Latinos in the United States, their ancestry is 51% Amerindian, only 46% European, and only about 3% African. In Peru, the ancestry of Peruvians is 80% Amerindian and only about 18% European and only 2% African. In Colombia, we see a national admixture that's similar to what we see in Puerto Rico, although a higher amount of Amerindian ancestry. But even within different states and locales in Colombia, we can see very different admixture profiles. Next slide. So, for example, in the city of Medellin, we see an admixture profile that looks very much like the national average, meaning mostly European, a solid up to a third amount of American Indian ancestry, but very little African ancestry. Now, in the neighboring state of Choco, which was a site of plantation agriculture, we see a much higher percentage of African ancestry. Okay, similar to what we see in African Americans, although I would say there's a much higher percentage of Amerindian ancestry in the residents of Choco than what you would see in African Americans. This point that I'm making here is that all these people consider themselves Colombian, and if you were to tell them, well, you're not Colombian because you're Black, they would look at you like you were crazy. Next slide.
Okay, so I don't know whether you're all sitting and thinking, wow, this just sort of blew my mind. It actually certainly blew mine the first time I saw this. I think it really just demonstrates the dangers in assuming that this giant category of a socially defined race has any particular meaning as far as it comes to genetics or biology. So race is clearly not a biologically useful construct. But at the same time, we know that there are so many racial disparities in health and disease. So why is this? So there are a variety of ways that we can look at causes of disparities, and I'm going to separate them as intrinsic and extrinsic. So intrinsic are going to be genetic causes. So for example, a selective advantage, as we saw in the incidence of sickle cell and the other hemoglobinopathies. And this is going to be based on geography, but not based on socially defined race. As you saw, we had Southern Europeans, people in the Middle East, as well as African India. So that's not one particularly socially defined race. Now, we also can have a founder effect or a population bottleneck. So this is when, for example, you have a decimation of a population like we see with the American Indians during the genocide in our country, and is what accounts for the increased incidence of severe combined immunodeficiency in that population. But that's not affecting a race, it's affecting a small subgroup of the Navajo and the Apache. It's a population, not a race. And then we have endogamy, which means marriage within, but more specifically, of course, breeding within one's particular group. And that can be based on religion or caste or geography. But again, these are not socially defined races. These are populations. Now, while we spend a lot of time and a lot of money doing research on subtle genetic variations and allele frequencies between socially defined races, which I hope the material that Dr. Graves showed you about the variability in population admixture convinces you is meaningless. Although we spend a lot of time and money on that, what you all know really is causing those disparities are the extrinsic causes. So poverty, access to care, living conditions, health insurance, neighborhood, food access, all of these have a tremendous impact on health. And all of them are colored by racism. So individual, institutional, and systemic racism. I'm going to take a moment to talk about these three types of racism based on the website dismantlingracism.org. And I generally would say at the beginning, I'd say, personal racism are individual acts. And being in North Carolina, I think of that as a man in a white robe burning a cross. And I used to say something along the lines of, but that's an individual act. We're really talking about institutional and systemic, which has a much broader and uniform impact. But what we've seen recently in the United States has shown us that personal and institutional and systemic racism are all very closely intertwined. Now, institutional racism is the policies and practices of institutions like universities and hospitals that include and serve and uplift white people at the expense of populations of color. So an example of this would be in healthcare, that when phenylketonuria testing was first initiated in that first clinic, they said, oh, we're only going to do white children because Black kids don't get this, right? Which we now know, of course, is not true, but there's just this assumption, and we can see some of this regarding other types of testing as well. Now, cultural or systemic racism are the beliefs, values, and norms of a society that, again, financially resources and validates and protects white people at the expense of populations of color. And I think the clearest example of this is that in our society, we do not believe in universal access to healthcare. And that has a huge impact on health disparities. So let's take a look at some of these extrinsic causes in the literature to see how they have an impact on health. So this is a quote from Up to Date based on the two articles listed here. And as you're aware, there are a couple of different ways that a hysterectomy can be performed. It can be an open hysterectomy in which there's a transabdominal incision, which can be fairly sizable, or it's possible to have a minimally invasive technique, so a laparoscopic hysterectomy or transvaginal hysterectomy. And what these studies showed is that when they looked at women who were eligible for either type, that Black, Hispanic, and publicly insured women were less likely to get a minimally invasive technique compared to white women. Now, an open hysterectomy has significant morbidity to it. It takes a long time to heal from it. You can't lift heavy objects. You will have to, and we're talking about a population that may be doing some sort of frontline work or have to lift heavy objects as part of what they do. Perhaps they don't have childcare. And so we are taking a population that's already vulnerable and we are making it more challenging for them. And as we look at these possible contributors, I would say that these are the ones that jump out at me. I would say systemic racism because of the link to public insurance, institutional racism because the hospitals that served these populations tended to have fewer surgeons who performed minimally invasive techniques, poverty, education, access to care, and health insurance are all variables. And then if we look at this quotation from the 10th edition of Robbins about the pathologic effects of high blood pressure in African Americans, we would say that all of these contribute to this. There is no slavery gene, right? All of these are going to contribute to this in this population. So now that we look at this, what do we do next? How do we as healthcare systems make things better? And this is some that I prescribe. First, a thoughtful, mindful analysis of the material driven by data, inclusivity, and context. So let's take a look at what it takes to look at the data. The first question, of course, is, are the data even true? So let's begin with this sentence, which was in the 10th edition of Basic Pathology. Now, I showed you at the beginning this list of more than 35 diseases associated with disparities in health by socially defined race. And one of the things that I did for my students was I then did a deep dive into literature for each of those diseases to try to understand what the factors were and what was contributing to these disparities. And that ended up being an 85-page document with figures and references. It's pretty extensive. So as I was looking at what had been written in the previous edition, I emailed the author of that particular chapter and I said, you know what, I really think you need to remove that part about African descent. And he said, this is what it says in Up to Date. Now, because of my disparities document, I had in fact already read Up to Date, and I'd also read this Article 5, in addition to about 30 other articles on keloids. And this is what is said in Article 5. I'll come back to the 5 to 16% in a moment, But one of the things that caught my eye in this particular article was this incredible statistic that the risk of developing keloids is about 15 times higher in dark-skinned individuals compared with whites. Now, that's a big number. It's got to be statistically significant. We'll get to the clinical relevance in a bit. But one of the reasons why this number stuck in my head is because, first of all, it was so big. And second of all, because I saw it in so many other papers. So this was in 4 other papers. And it looked to me that the first incidence of this came in 2001. That was the earliest quotation. So let's go ahead and take a look at what Brissett says. And he says in a review of 175 cases of keloids from various races, the authors found that keloids were 15 times more likely to occur in darker skinned individuals. So let's pull that paper by Ahadi and Sivanatharah, which is from 1969, which may have been the heyday of keloids research. It was done in Indonesia, hence these are the populations they examined. And this is what they actually say, that the relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. So Brissett not only gets the number wrong, a 2 to 3-fold difference, but the arrow is pointing in the wrong direction. So I put all of this to the author, and we made a change, which I'll show you in a moment. But first of all, let's look again at this number that we have, this 16%. So in order to get into this, I did this really determined dive, going all the way back 90 years to find a paper written in French from the Society Proceedings in Strasbourg, France. This was a dermatologic society. And in this, Monsieur Lespin from Belgium gave a talk on tattoos and keloids in Negros of the Congo. And after he gave his talk, as so often happens at meetings, someone gets up, doesn't ask a question, but says, hey, wait, I did some research on this too, and proceeds to give this long disposition. And that was Mr. Staub. And what he said is, while I was in the Congo, I'm also Belgian. And this is at a time, remember, when the Congo was being savagely exploited and colonized by the Belgians. What it occurred to this guy to do was to go to the mines and look at all of the adult workers. So he looked at 1,200 adult Black workers, and he looked at them for keloids. And what he said was, after I did this, I found 16% had keloids. So that's where this number comes from. 90 years later, one person looking in one part of one country in Africa, which, as you know, has more genetic diversity than the rest of the world, and says, this is the number. And 90 years later, it shows up in up to date. Now that's bad enough, but there's something else which I think shows you the depth of systemic racism in the literature. Because at that exact same meeting, on that exact same day, this other professor, Professor Nagli, who lived in Switzerland, said, hey, I've actually got some research of my own. I was looking in Switzerland at adults who had keloids. And what I found is that Swiss adults, 13.3% of them had keloids. Now, if you look at this, even if you are a statistician and you're thinking, okay, maybe this is statistically significant, we have a difference of 2.7% between these two populations. Now, again, looking at these data, we can't say that Dr. Nagli's data speak for all Europeans. They speak for one city in Switzerland. But what number has come down to us through 90 years? It's been the, oh, look, Africans have a higher risk of keloids. So let's return back to what we actually have in the textbook. So after I presented these data to my colleague, this is now what it says. Keloid formation seems to be an individual predisposition, which it does. And it makes me think, well, why are we even associating with race in the first place, right? Part of it is the habit. We've been doing this for 90 years. It's in every book where you look at keloid formation. Everybody says it's associated with African descent. But why are we looking at race? Why are we looking at the color of someone's skin? Why don't we look at the patient's actual skin? Because if someone is going to get a keloid and they're presenting for some sort of elective procedure, if you look at their skin, you'll know if they have a tendency to have keloids, because we've all had some sort of cut or scrape or piercing or multiple piercings. And if we're going to get a keloid, we'll have a keloid. Okay, well, what about for children? Fair point. Now I had a fairly traumatic childhood running around being a tomboy, so I had lots of opportunities to find out if I was going to get a keloid. But if you have a kid who has had a very safe existence, what you can do is, since we know that keloids tend to occur in families, you ask brothers and sisters, cousins, aunts, uncles, father, mother, grandparents, do they have keloids? And that's going to give you a clinical history that will help you to determine if this person is at risk. And this isn't just for keloids, right? This is for all diseases, because if you take a very good family history, that's going to help you not only with genetic issues, but also cultural. Is there a food they tend to eat or folk medicine? That's going to help you recognize what else might be affecting this family. And getting that family history is going to do far more to tell you about that one individual's genetic background than any amount of looking at the color of their skin. So as you can tell, I'm quite passionate about this. I have a website and I have videos on that. And I did a 21-minute exposition just on keloids. And Dr. Graves and I also have a paper out in New England Journal. Now, when I put this video together, I sent it to the authors of that up-to-date article. And I said, you know, you might want to redo this. They said, oh, heavens, yes, we should do something about this. And not much happened. And then they did fix it after several. I kept emailing, and eventually they changed it. But they didn't change all of it. There was still something in there in genetics. And so in our New England Journal article, Dr. Graves said, oh, by the way, and up-to-date, it still associates this with socio-defined race. And after that, which I sent to them, they then removed it. So this is what we saw when you first started. This comes from November of 2021. You can see the quotation there. This is what it says now. So science did prevail. But I will tell you, you know, that this is the approach I have for any time that I see a racial association with a disease, to do that deep dive. But I will tell you, as soon as you do this, there will be pushback. There will be the, but what about? Here's a paper that says this, and there's this other paper that says that. So first of all, we have to recognize that just as that one Monsieur Staub's exposition on this one area in this one town in the Congo doesn't apply to all Africans, much less African Americans, that a single study in a particular area can't be used to go for a whole socially defined race. So these are two studies that have been cited saying, yes, race is really important with keloids. This one did 429 patients and found about 7% of African Americans had keloids compared to 0.5% whites, showing an odds ratio between these two populations of 16.5%. Here's another article with a lot more patients, and we can see that the incidence is very different, 0.8% and 0.1% with a different odds ratio, which tells you what you already know because of what Dr. Graves showed you about looking at population admixture, that how can you look at specific populations if your populations aren't specific? And then we have to ask, okay, well, here's another question. Even if it is true, is it clinically relevant? Right. So here's an example looking at lupus and this is these are data from up to date where we see that they cite that lupus is seen in about 164 per 100,000 European American women and about 106 to 100,000 African American women. But if you pull that actual study, you can see it was actually looking at two different states, and there's a difference even there comparing these two populations. So why do we compare this? Is it to help us come up with that differential diagnosis? Because what we don't do is we don't pick, you know, 1,000 white people and 1,000 Black people and say, one of you has lupus and 4 of you do. No, a patient comes to us with suspicious signs and symptoms and laboratory values, and we try to determine if that person has lupus. And we do this using laboratory tests. And so one thing that has been suggested to me is that knowing these different epidemiologic data will help you with the sensitivity and specificity of your tests as far as your positive predictive value. So let's look at that. If we look at comparing, and just to make it simpler, I did 1 in 100 versus 4 in 100 in contrast to these numbers. If you look at that and you have a test that's 95% sensitive and specific, you can see that the positive predictive value in these two populations does differ. That in an African-American woman, you'd have a 44% chance that person actually has lupus, as compared to being less likely in a European-American woman. But when we go to the actual incidence, both of these tests are essentially meaningless because we don't use a single test, just looking at that, not looking at the patient, not doing a clinical history. We have to put it all together. But despite this, and despite all the work that Dr. Graves and I have done in the for the 11th edition of Robbins Basic Pathology, the belief in biological race remains, and this is what it will say in the 11th edition. So that is the data approach to how you make change, but how do you know what to look for, and how do you be sure that you're listening to everybody. Because I see the world through my eyes. I've learned a lot from Dr. Graves, you can see here, but there are a number of people and I have to sound out all of them so that I can keep myself honest, because it's so easy to see from my point of view. So you have to build your team and not just, talk with them, actually hire them, pay them for what they do. It's really important to empower them. And it's not just looking at faculty and instructors. We need to bring in the students and the trainees, because I will tell you, they are far ahead of us, okay? Much of this work is being driven by students and trainees. The goal of these talks that Dr. Graves and I give is in many ways to bring some of the older faculty up to speed, right? Because the students and trainees are expressing frustration with why are we still talking about race in this, that, and the other? So what I did for my students, I put up a Google Doc saying, hey, we're working on the next edition. If you see anything, just put in the page, the terminology, and a few notes. It's anonymous. I'll check it out. So we have to really open ourselves up and ask students and trainees for their input. And this can be challenging because it's very difficult to talk about race, and because there's a lot of vulnerability in this. And I believe in being vulnerable and transparent when I'm uncomfortable. So that's an edge I encourage all of us to lean into. We need to be inclusive, not just with our personnel and our trainees, but with our images. So at Duke, we teach pathology from a website, and I removed race and ethnicity from all of the vignettes 5 or 6 years ago, but we still had clinical images, and you don't need this to say a 62-year-old European American man, because you can tell by looking at this image that this is most likely someone of European descent. But what we recognize is that it's not enough just to simply show this image. We show now in multiple skin types. And this is critical, right? This is a basal cell carcinoma. And to me, as a pathologist looking at this, I'd be worried about a melanoma. It's darkly pigmented, it's got some ulceration, it's irregular in shape, right? And if we don't teach our students that things look different in different skin types, how can we expect them to give equitable care? And finally, we need to use appropriate terminology and provide context. So I believe that if we are going to mention socially defined race in context, we need to explain why this shows up. You just don't say 2 to 15% of whites carry this mutation, right? We know that this is actually genetic, so it's an intrinsic cause. So we want to amplify the fact that it's ancestry, not socially defined race. And we don't want this to be a sort of a dog whistle or a hint. When Deyrup says European ancestry, she really means white, because we know that because of population admixture, that we can see factor V Leiden in a variety, and pretty much anybody could have factor V Leiden. And this is important because heterozygotes can be thrombophilic. So you don't want to look at an African-American woman who's presenting with multiple symptoms that are suggestive of thrombophilia and think, oh, she doesn't have factor V Leiden because she's not white. So that brings us really to the end of our talk. And I added this slide because we've gotten to the end, and the question is it true that nearly everything you learned in healthcare training about race is wrong? Is it true? Please put in the chat yes or no. I'm not going to look at that. I'm going to give you the answer, what I think. Yes, it is true, because what we all learned, and it's not just in healthcare training, it's what we learned in kindergarten, right? We learned this all along, that biological race existed. And because so much of medicine is built on the foundation that biological differences exist between races, I would say nearly everything you've learned in healthcare training about race is wrong. Now, socially defined race has a tremendous impact on health disparities. Absolutely no question, right? But that's not what we're talking about. When we talked about hypertension in Robbins, in African Americans, yes, that's socially defined race, and we need to add in something. This has to do with access to care, systemic racism, things like that. Here's a list of our references. I'm going to end here with a couple of things. You can email me. Both of us are on Twitter. You can see our Twitter handles. I have a website on which you can find multiple videos about race and medicine, as well as about pathology. And I'd like to direct you to this cartoonist. She's a cardiology fellow at the University of Chicago. She has a new book that's just come out, which is a novel called On Rotation. But I love her work because I think it really puts it together in just an image, and you can find her at her website. You can follow her on Twitter as well. So with that, I will stop sharing and we will take any questions. And I'll read the comments. Yes, I agree. The Taiwan example is simply a factoid with virtually no significance. Awesome training and hard truth. Yes. Yes, Dr. Sharma, I am working very hard on it. It has not been the rousing success that Dr. Graves and I had hoped for. It is much, much better, and we have multiple representations of skin of color. Before, almost all of the images in the textbook were in lightly pigmented skin, but we've done a lot to correct that. And we have a section on health disparities, and we mention racism. So we're doing what we can to help our students.
There was a hand from Kim Scott.
Hi there. So sorry, I inadvertently raised my hand, but I will ask a question if that's okay.
Absolutely.
So I'm curious how you would recommend reporting on racial demographics in studies or in professional training programs if we know that this is a socially derived construct. How do we encourage representation and at the same time not reinforce sort of socially derived ideas about highlighting kind of broad racial categories that may be meaningless? Does that make sense?
Absolutely.
Yeah,
Joe, I'll let you take it and I'll follow up.
Yeah, I mean, this is rather simple. What you're reporting is sociological data. So you're basically reporting social determinants of health. You're not reporting, polygenetic polymorphisms that are responsible for differences in health outcomes. And that's what you need to get across. And I believe it's really important to report that kind of data because that helps us be able to intervene to do preventative care. But the point is that you really have to drive home and reinforce the fact that what you're not reporting is biologic race and genetic polymorphism. You're reporting differential exposure to various risk factors, many of which are the result of structural racism.
So
Helps.
So I think that this is an important point. And I put in the chat, I really would recommend that everybody read the first 3 to 4 chapters of Dorothy Roberts' book, Fatal Invention, which talks specifically about research and the use of socially defined race. So this is important for inclusion, right? If we didn't note socially defined race, we wouldn't know which populations aren't being vaccinated, for example. And knowing that, we're able to make interventions and say, okay, this population isn't getting vaccinations. Are they not able to go take time off from work to go to the hospital? Maybe we should go to the church and do something there. Is there some way we can help this? So the socially defined aspect of it is good for dealing with these public health issues. And it's also important because if we don't look at that, we can't fix it. The problem is that humans are now so hardwired to believe that there is a biological difference based on race that I have a fellow Robbins editor who wrote me an email saying, well, of course, I don't believe in biological race. I don't believe biological races exist, but you really should mention that African Americans have more aggressive prostate cancer that affects them at an early age because of biological and genetic differences. I'm like, but wait a second, we just said they're not associated, they're not a biological race. Well, but they've got biological differences. I'm like, that's exactly it. So one of the challenges, and it's talked about in this book, is that, and I know Dr. Graves has also written on this extensively, is that the NIH recognized that almost all of the in almost all clinical trials, it was mostly, white men. White men are great for clinical trials, particularly if you use, people from the military. They don't have hormones that cycle on a monthly basis like women. They're very accessible. They can take time off of work, whatever. And so they started saying you have to report the socially defined race of your study participants. Now, what happens is you do a study and there's nothing particularly remarkable, but you found this difference based on socially defined race. And why is that? Because subordinate races are exposed to more toxins, more stress, racism, worse food, job insecurity, all of these things. And so, of course, there are going to be differences based on socially defined race. Now, one thing I think you can do to address this is to, as you've probably noticed, Dr. Graves and I always use the term socially defined race. We don't say, well, if you look at different races, we say, if you look at different socially defined races. And this is something that really frustrated the other editors of Robbins. But for me, I do that because otherwise it's so easy for us to shortcut to biological race. If I say there are differences between races, there's this belief they must be biological. So maybe that helps as well.
Andrea, can you see the blue screen with the activity code?
I can.
Okay, great. I just wanted to make sure that that was sharing. I want to thank Dr. Graves and Dr. Deyrup for so much clarification of many biological constructs and causes of disparities, and giving us some tools of how we might be able to close those gaps. I appreciate your time, your willingness to share your knowledge, and I love that they gave you their contact information so you can continue the conversation and ask questions.
There's a question from Jeffrey Kemp that I know that Dr. Graves is ready to leap on because we've talked about this before. Do cortisol levels play a role in health disparities between races?
Sure they do. But the question, of course, is why are there cortisol differences between socially defined groups? And as you know, cortisol is part of the it interacts with the HPA axis, which, is something that people respond to with regard to external sources of stress. So one would not be surprised that individuals who are socially subordinated should have higher levels of cortisol, should have experienced more stressful life events. Now, I spend a lot of time on that problem in chapter 5 of Racism, Not Race, but there's also been a bevy of studies done in non-human primates showing the exact same thing. In fact, there was an excellent review in Science, I think it was last year, years fly by due to the pandemic. I'm pretty sure it was Jenny Sung from Duke and her group that showed this across all primates. So it's not at all surprising that you find cortisol level differences in groups of individuals who face dramatically different social circumstances. It's been shown in other animals as well.
All right, well, thank you for your time and attention. Please feel free to reach out, check out the resources. I highly recommend Dr. Graves' books, as well as Fatal Invention by Dorothy Roberts. Follow me on Twitter and you can see what we're up to and where we're going, what we're doing. And thank you very much. And I hope we've given you some food for thought.
Yeah, thank you all for your attention this afternoon.
Thank you so much to both of you. Appreciate it.
Bye-bye.